Good morning and welcome. Thank you for joining us today. I'm Kim Johnson, Secretary for the California Health and Human Services Agency. Next slide, please. For those who might need interpretation, we have sign language interpretation available. On the interpretation bar on your Zoom screen, you can also select American Sign Language to be able to see the interpreter throughout the course of today's webinar. Next slide, please. This is the third webinar we've held focused on the impacts that various health and social service federal policy changes have had for California. This webinar today is being recorded and will be posted on our website where you can also find the other two webinars. As of today, top of mind, October 27th, the federal government shutdown continues due to the failures of the president and Congress to continue government funding. Millions of Californians receiving benefits from state programs may be impacted. We are currently prioritizing access to food and nutrition resources, which are at greatest risk. The California Women, Infants, and Children, or WIC program, has received additional federal funds from the United States Department of Agriculture, such that as of today, we project WIC to remain fully operational through November 30th, assuming no unexpected changes at the federal level. The federal government has indicated that states cannot issue SNAP, or what we refer to as CalFresh, benefits for the month of November. In response, this past Friday, Governor Newsom deployed Cal volunteers and the California National Guard on a humanitarian mission to assist food banks across the state. We are also fast-tracking $80 million to food banks. You will hear more about these efforts shortly from the Department of Social Services Director, Jennifer Troia. In addition to the federal shutdown, as you may know, earlier this year, the Republican majority in Congress and President Trump enacted H.R. 1. The funding and policy changes contained in the bill will reduce access to critical healthcare services and access to food and nutrition resources for millions of Californians. One of the provisions of H.R. 1 created significant impacts to Planned Parenthood, prohibiting them from receiving Medicaid funding for any services they provide, including family planning, STI services, and primary care. As you may have seen, in the Governor Newsom's press release dated October 23rd, the governor and legislature have now allocated more than $140 million to Planned Parenthood to maintain access to critical clinic care, including reproductive health services and abortion care. This funding comes from state funds made available for reproductive health care. The administration will work collaboratively with the legislature for early action in 2026 to seek additional funds to retain reproductive health access for Californians for the remainder of the fiscal year. You have also seen the actions we've taken to ensure continued access to life-saving vaccines, as we've discussed previously in a webinar. All to say that here in California, we will continue to mitigate the harm of these federal changes wherever we can. This is also demonstrated via litigation that we have partnered with the Attorney General's office to file. Over 24 lawsuits are focused on health and human services. We also need your partnership in this effort, which is why we are here today, again, transparently sharing the information we have and the evidence-based and community-informed approaches we are taking with the hopes of enlisting your input and support. The Director of the Department of Healthcare Services, Michelle Baass, and the Director of the Department of Social Services, Jen Troia, have joined me today to share the latest information related to implementation efforts impacting Medi-Cal and CalFresh, respectively. Today's session will also provide an update from Healthcare Access and Information's Director, Elizabeth Landsberg, on the state's draft application for the Rural Health Transformation Program aimed at strengthening healthcare across rural communities. These efforts are significant lifts from all three departments, and I thank the directors and their teams for all that they're doing. With that, I'll turn it over to Director Baass with the latest on impacts to Medi-Cal.
Good morning. Thank you, Secretary. Next slide, please. Next slide. Medi-Cal serves nearly 15 million Californians, roughly 35% of the state, including 5.5 million children and teens. It supports older adults and individuals with disabilities. It is more than just healthcare, it's a lifeline for the Californians it serves, providing access to vital medical and dental services, preventive care, mental health support, substance use disorder treatment, and care for chronic conditions. H.R. 1 makes sweeping changes to the Medi-Cal program and will cause widespread harm by making massive reductions in federal funding and potentially cripple the healthcare safety net that all Californians depend on. These changes put tens of billions of dollars of federal funding at risk for California and could result in a loss of coverage for millions of Californians. In particular, the provisions of H.R. 1 that apply to Medi-Cal focus on restricting eligibility and access requirements. This includes work requirements, semi-annual eligibility checks, restrictions on retroactive coverage, and new cost-sharing requirements. State financing restrictions, which include limitations on state funding mechanisms such as provider taxes and state-directed payments, which are vital to Medi-Cal, and penalties related to improper payments. Immigrant coverage limitation. This includes reductions in the federal matching rate for emergency services for individuals with unsatisfactory immigration status and restrictions on lawful immigrant eligibility. And as the Secretary mentioned, a one-year ban on abortion providers receiving federal Medicaid dollars. These changes will impact our emergency departments, rural hospitals, private and public hospitals, community health centers, ambulance providers, and the broader healthcare system that serves every community. Next slide, please. As you can see, the provisions of H.R. 1 go into effect over the course of the next 4 years, with some of them taking effect immediately upon enactment of H.R. 1 and others not starting until 2029. Next slide. Some of the key effective dates for the eligibility and access changes are January 1st with the implementation of mandatory work requirements. And today, as webinar, will go into more details on this particular provision, the semi-annual redetermination process and retroactive coverage starting January 1, 2027, and then the imposition of co-payments starting October 1st, 2028. Next slide. With regard to some of the payment and financing restrictions, our provider taxes, some of these changes went into effect immediately upon enactment of H.R. 1, and others take effect October 1st, 2027. Next slide, please. Similarly, for the state-directed payments and some of the audit waivers, some of the changes went into effect immediately upon enactment of H.R. 1, and others go into effect January 1, 2028. And then finally, next slide, please. Our immigrant coverage changes go into effect October 1st, 2026. Next slide, please. As we think about implementation of these provisions, we will be coming out with a comprehensive H.R. 1 implementation plan later this year to guide implementation of these changes in California. Ongoing work groups with counties, managed care plans, advocates, and community partners are shaping policy and streamlining operations to support implementation readiness. Regular updates are being shared through our stakeholder forum, work groups, and established communication channels to keep partners informed and engaged. At this week's Stakeholder Advisory Committee, we will be going through a deep presentation on H.R. 1's impact to Medi-Cal. Email address on this slide to learn more. Next slide, please. Work requirements. Today, I will provide some updates related to the implementation work requirements required under H.R. 1. Next slide. As we work on implementation details, we are guided by the following principles. Automate to protect coverage. We want to maximize the use of data sources to confirm eligibility without burdening members, reducing paperwork, and streamlining verifications so that we can safeguard coverage. Communicate with clarity and connection. We are implementing an outreach and education plan that is culturally relevant, linguistically accurate, and written in plain language to build trust and help members understand the changes. Simplify the renewal experience. Modernize and streamline the Medi-Cal renewal process with a clearer, member-friendly form and a 6-month renewal steps that are easier to navigate. Educate and train those who serve Medi-Cal members. We plan to deliver comprehensive training on all HR1 provisions for county eligibility workers, provide clear policy guidance, practical tools, and ongoing training and technical assistance so counties and our coverage ambassadors can confidently support members. And then finally, provide timely and transparent communication to members. We want to share information early so members can build awareness, anticipate changes to their coverage, and have ample time to prepare to meet new requirements. Next slide. With regard to work requirements, HR1 requires states to condition Medi-Cal eligibility on compliance with work requirements, also called community engagement requirements, for adults ages 19 through 64. Implementation is set to begin January 1st, 2027. States can request implementation delay for up to 2 years through December 31st, 2028 from the Federal Health and Human Services Secretary, as long as the state is making a good faith effort to come into compliance. More details on this process are forthcoming from the federal government. At minimum, states must verify compliance with work requirement at both application and renewal, requiring individuals to demonstrate completion of 80 hours of qualifying activities for at least 1 month prior to application, and once enrolled, at least 1 month with every 6-month period. Additionally, individuals who are discontinued as a result of not meeting this requirement cannot access subsidized marketplace coverage. We estimate the impact to California to be up to 3 million Medi-Cal members that may lose coverage and a loss of over $20 billion in federal funding as a result of this provision. This would significantly drive up the uninsured rate and raise costs for hospitals treating uninsured patients. Next slide, please. With regard to how to demonstrate meeting these work requirements, an individual may be employed 80 hours a month, have monthly income of at least 80 times the federal hourly minimum wage, so $580, community services of 80 hours per month, enrolled at least half-time in an educational program, or participation in a work program of 80 hours per month. The law outlines mandatory and short-term hardship exemptions, and these exemptions must be verified every 6 months. Next slide, please. With regard to the mandatory exemptions, these include children under the age of 19, individuals eligible for another mandatory eligibility group, foster youth, former foster youth under the age of 26, parents and other caretaker relatives of a child under 13, pregnant women and those entitled to postpartum coverage, individuals receiving supplemental security income, and individuals entitled to Medicare Part A or B. Next slide. Additional mandatory exemptions include American Indians and Alaska Natives, parents and caretaker relatives of a disabled child, dependent child, 13 years or under, or a disabled individual, veterans with a disability rated as a total, medically frail individuals or those with special medical needs, individuals needing temporary assistance for needy families, individuals in compliance with SNAP work requirements, individuals participating in a drug or alcohol treatment program, and inmates of a public institution recently released from incarceration within the past 90 days. Next slide, please. Additionally, HR1 provides optional temporary exemptions, and this includes individuals living in a county impacted by a federally declared emergency or disaster, living in a county with a high unemployment rate, receiving inpatient hospital care, nursing facility services, services in an immediate care facility, or traveling for an extended period to access medically necessary care. Next slide, please. At the high level, the process to assess work requirements has 3 steps. First, to gather self-attested exemption or work reporting requirement information. Next, to conduct ex parte to determine if someone meets an exemption or work reporting requirements. And third, if unable to verify work activities or exemptions, applicants and members will have 30 days to demonstrate compliance that they meet an exemption or these requirements. Next slide, please. In the next few slides, I will highlight some examples of data sources we are considering to automate the verification of this requirement and/or the exemption from this requirement. For verifying compliance with meeting the work requirement based on income or hours worked, we are considering various potential data sources, including state quarterly wage and IRS data, work number information, gig economy data, and then for our veterans, veteran service history and eligibility application programming. Next slide, please. Now for some examples for how we might verify exemption from the work requirements. For these exemption categories, we will use data in our existing systems. So for children under 19, pregnant or postpartum, foster youth and former foster youth, age and disabled, parents, caretaker, relatives, and inmates, we have eligibility and aid code information to use to automate this process. Next slide, please. Similarly, with regard to medically frail, using our claims and encounter data and automatically exempting certain individuals who may be receiving home and community-based waiver services, PACE, potentially evaluating enhanced care management and community supports eligibility criteria, using the International Classification of Diseases, or ICD-10, and procedural terminology to identify diagnosis and utilization data that meet medically frail definitions, and also exploring other potential data sources. Similarly, using our short Doyle Medi-Cal system to exempt individuals who have a specialty mental health claim or drug Medi-Cal claim as well. Next slide, please. On this side, we've included examples of cross-state data sources for verifying compliance or exemption. Some of these examples includes data from our California Department of Social Services with regards to TANF and CalFresh work requirements, part-time education for our UC, CSU, and community college data sources, and then the Department of Rehabilitation for 80 hours of work program participation. Finally, next slide, please. We recognize the critical importance of communication outreach. We want to communicate with clarity and connection and want to provide timely and transparent communication to our members. As such, we will be implementing a phased outreach campaign in all threshold languages using culturally relevant and plain language materials. Our coverage ambassador model will continue leveraging trusted messengers and local partnerships to reach diverse communities. Outreach will include FAQs, scripts, templates, translated materials, toolkits distributed through our website, social media, flyers, and direct outreach. Communication will focus on equity, language access, and early awareness, with messaging aligned to implementation timelines and member actions. Thank you for listening today, and now I will turn it over to Director Troia at the California Department of Social Services.
Thank you so much, Director Baass, and thank you all for being here with us today. I'm going to focus my updates on HR 1 implementation with respect to the CalFresh program in particular. In many instances, we have clarity on the path forward for implementing HR 1 changes, which we have discussed in the prior webinars. But in some key instances, we are still waiting for federal guidance or other information that is needed. The federal government shutdown is also impacting the CalFresh program significantly and the people we serve, and I will briefly talk a little bit about some of those impacts at the end of the presentation as well. If you could go to the next slide for me, please. The information in this slide is a repeat and a reminder of the importance of CalFresh across our state. It's the state's largest anti-hunger program, serving more than 5.5 million Californians and 3.3 million households across the state. It is one of our most effective tools to combat poverty and food insecurity. Go to the next slide. So as a quick reminder, also want to share this slide with you to highlight the significance of the changes that HR 1 includes to the SNAP program, or CalFresh in California. HR 1 is estimated to cut federal funding for CalFresh in California by at least $1.7 to $3.7 billion annually. We initially estimated as many as 395,000 people could lose benefits as a result of the policy changes included in HR 1. Including children, parents, and caregivers, people with disabilities, immigrants, people who are experiencing homelessness, current and former foster youth, and college students. Again, there are greater details on the overarching provisions of HR 1 included in the prior webinars. We go to the next slide. As we implement the changes in HR 1, we are committed to being very intentional and to working collaboratively with our partners. This slide highlights some of the guiding principles that we're using to help ground us as we navigate these very difficult times. They are to first mitigate harm whenever possible. We want to make timely decisions that minimize negative impacts and ensure clear communication for clients and for counties. Also, to continuously improve. We want to identify the opportunities and to streamline existing and new processes, support and stabilize the safety net, and center client and county user experiences. We are also focused on evidence-based decision-making, using data and research to inform our decisions, monitor progress, and help us make adjustments as necessary. And finally, we are committed to engaging transparently. We want to seek insight from our partners, including the counties that administer CalFresh, people with lived experience, and many others whose perspectives are very important to us. Next slide, please. With that, I want to get into some more detailed implementation updates where there have been changes since the last time we spoke. First, as a result of HR 1, the federal government is no longer approving the state to include internet costs when determining the value of the federal fiscal year 2026 standard utility allowance. So this is effective now. It was effective October 1st of 2025, and it essentially lowers the costs we take into account and impact the amount of benefits that people will receive. Second, as a result of the reevaluation of the Thrifty Food Plan, which is used to determine benefit amounts, the state implemented new benefit amounts for households of 18 or more people, effective October 1st, 2025. Finally, in terms of nutrition education funding, we submitted a new CalFresh Healthy Living Plan for federal fiscal year 2026. That plan was recently approved, and it does allow the state to spend federal fiscal year 2025 funds, so funds we already had, through September 30th of 2026. Next slide, please. We are also about to implement federally required changes to who can claim the standard utility allowance. So quickly as background, California provides a low-income home energy assistance program payment known as the Standard Utility Allowance Subsidy, which allows households who are not otherwise able to claim the standard utility allowance. Effective October 31st, however, so later this week, that energy assistance payment will newly be limited only to households that include an older adult or a person with a disability. We issued an all-county letter in September letting our county partners know of the change, and we estimate that approximately 185,000 CalFresh households, or 444,000 individuals, will see a resulting reduction in their CalFresh benefits. Next slide. Another big development regarding HR 1 is that on Friday, October 3rd, the Federal Food and Nutrition Service released two long-awaited policy memos and changes to several policies related to the CalFresh time limit for individuals who are considered to be able-bodied adults without dependents, or ABODs. This is a series of major changes, and we had been anticipating this guidance for some time. So let me walk through quickly the details of these policy changes and the status of implementation in California. Next slide. This slide provides an overview of the CalFresh time limit and work requirement rules, including the qualifying activities that allow individuals to maintain benefits. First, the term able-bodied adults without dependents, or ABOD, now includes or refers to adults ages 18 to 64. California also currently has a statewide waiver of the time limit for ABODs. It was previously set to expire January 1st, 2026, but the new FNS guidance now ends California's waiver on November 2nd, 2025. I will note that on October 6th of this year, we did submit a request to FNS for a new waiver of the CalFresh time limit in 3 counties, Colusa, Imperial, and Tulare, based on the new ABOD waiver criteria. We received word on Thursday, October 23rd, that ABOD waiver request for those 3 counties was approved. The waiver is approved for those 3 counties only from November 1st, 2025 until October 31st, 2026. Next slide. There are some exemptions to the ABOD time limit requirements, which we've listed on the screen. We've indicated the new changes in red. So these are new exemptions from the ABOD work rules for individuals 18 up to 64. This is actually taking away an exemption in the sense that it was previously from ages 18 to 54. So we now have older individuals who are also included within this policy. Similarly, we have more caregivers who are caring for dependent children who are now included in the policy. It used to be that a caregiver who was caring for a child under the age of 18 was exempt, and that exemption has now been narrowed to caregivers who are caring for children under the age of 14. A new exemption in the other direction, so providing a new exemption, is for Native Americans as defined in HR 1, which is listed here on the slide in a set of categories. Exemptions were also taken away for people who are experiencing homelessness, veterans, and foster youth. Taken together, all of these changes increase the number of people statewide who are considered ABODs and held to the time limit and the corresponding work requirement rules. We are working with our partners across the state and nationally to interpret the new federal guidance and to inform accurate implementation of these rules. This is very complex. These policy changes also need significant operational changes, including statewide training and automation. And we have not yet issued the guidance that counties will need to move forward in implementing these policies. At this time, state guidance about serving individuals who are considered ABODs has not yet changed. We're committed to ensuring consistent implementation statewide, including accurate implementation of exemptions and work requirements and pathways for people to maintain benefits. More information on implementation and the timing will be shared as soon as we have it. This is a priority for us, and we're committed to continuing to engage with our partners on this topic. We will move toward compliance with FNS guidance while also balancing the need for accuracy and clarity. Next slide. This slide updates current estimates of the numbers of individuals considered to be ABOD statewide, the numbers who are exempt from the work requirements, and the numbers who we estimate are meeting the work requirements, as well as those we estimate are at risk of losing benefits as a result of these provisions. Next slide. HR 1 also included significant changes that will cut individuals who are not citizens off of eligibility for CalFresh. We are still waiting for guidance from the federal government related to these provisions and have not issued any implementation guidance for these provisions. Once we receive information from the federal government, that will paint a clearer picture of the cumulative impact on the CalFresh recipient population. We will share updates as soon as we receive additional information about these changes from the federal government. Next slide. This slide is a little bit busy, but it does recap and update to the timelines for implementation of all of the policies, the major policies related to HR 1. These changes include the SUA policy implementation date and expiration of the statewide ABOD time limit waiver, which are updates from the last time you've seen this slide. Next slide. We are thankful that the legislature and the governor recognize the impact that HR 1 will have on the people of California and the workload that it will take to implement these many changes. As a result, the state budget for 25-26 includes a few key investments related to HR1 implementation. First, there's funding to support implementation of the ABOD work requirement. There is also funding to help us lower the state's payment error rate, which, as a reminder, will be connected in future years to the benefit cost sharing. We will engage in those efforts to lower the error rate through data and technology enhancements by developing a clearer understanding of what drives errors, potentially through policy changes, automation, and client communications. There is also emerging work as well on income verification improvements, which has come up a lot in work group discussions. Speaking of which, next slide. We are implementing a multi-pronged strategy focused on understanding the key challenges ahead in implementing HR1 and developing accuracy improvements that balance both accuracy with client access and county workload. We are actively seeking insight from those with lived experience and from partners representing a variety of local and state sectors. We've assembled 2 major working groups to help us navigate these changes. One is specific to the counties, and the second, the one I want to most bring attention to today, is called the All-Partner HR1 CalFresh Implementation Advisory Group. The purpose of this is to bring partners together to collaborate with CDSS and advise on implementation of HR1 provisions and strategies to improve accuracy. Our goal is to establish a shared understanding of the policy and payment error rate root causes, to share implementation updates, and to advise on all of our efforts related to HR1. This work group also provides opportunities to engage regarding the investments we highlighted on the previous slide. It convenes monthly, and some early priorities have emerged, including tackling income verification, enhanced root cause analysis from the client and worker perspective, implementation of the ABOD time limit, centering client voices in the long term. Again, we cannot do this work without collaboration and partnership from all of you to uphold the guiding principles we started out with at the beginning of this conversation. Next slide. With that, I want to briefly transition to talking about the dire moment that we're facing across California as the impact of the federal shutdown comes to bear on CalFresh recipients. October 2025 CalFresh benefits were not affected by the federal government shutdown. However, as President Trump and Congress failed to reach an agreement to reopen the government heading into the end of this month, we do now anticipate that November CalFresh benefits will be delayed for the more than 5.5 million people served by the program. The federal government released guidance just last Friday indicating that SNAP benefits or CalFresh benefits are suspended until the shutdown is resolved. We are working with urgency to make sure that CalFresh recipients know about this disruption and have information about where to find emergency food through food banks across the state. Last week, the governor also made sure that $80 million in state funding for food banks would be made available to the food banks as quickly as possible. In addition, the governor deployed Cal volunteers and the National Guard to support food banks who may experience a surge in demand for food. We are grateful to all of our partners who are working with tremendous urgency to ensure that Californians have access to food during this time of uncertainty. Next slide. In that spirit, I want to close out this presentation by lifting up a flyer, which also has a QR code that can be used to monitor updates related to CalFresh benefits and to connect Californians with food banks. We have posted the flyer in English and Spanish on our website, and it can be translated into other languages on that page as well. The web page that it links to also includes frequently asked questions and answers. So with that, I again want to close by saying thank you to you all for joining this webinar and for your collaboration as we work to mitigate the harm of the policies in HR1 and the federal shutdown impacts. This is a critical moment for the CalFresh program and the people we serve, and we deeply appreciate your partnership. I will turn it over now to Director Landsberg for an update on rural health initiatives.
Thank you very much, Director Troia. Good morning, everyone. Elizabeth Landsberg, Director of the Department of Healthcare Access and Information, here to talk to you about the Rural Health Transformation Program after those very sobering updates we had about the impacts of HR1. Next slide, please. So HR1 does include $50 billion to support rural healthcare transformation, to support rural communities. CMS, the Centers for Medicare and Medicaid Services, has made very clear that this is not to backfill the cuts that Director Baass talked about, but really to invest in long-term sustainability and changes to the rural healthcare programs and infrastructures in states. So on the right here, we see the 5 strategic goals laid out in the statute. The first one really focuses on chronic disease management, population health, really focusing on investing in prevention and early intervention to try to get improved healthcare outcomes. The second strategic goal is around sustainable access to strengthen the rural providers and to improve efficiencies, sustainability, and partnerships, really changing the way rural healthcare systems are working. And we'll talk about how California proposes to do that. The third strategic goal is around workforce development, really recognizing that we can't provide the healthcare that rural Californians need without recruiting and retaining skilled providers. The notice of federal funding opportunity talks a lot about community health workers, patient navigators, so it's really the full range of healthcare workforces and working as teams. The fourth strategic goal is around innovating care to advance new care models, to have better coordination of services, and to shift care to lower cost settings, really to try to change the way care is provided and paid for. And then the fifth, there's a recognition that there needs to be the technological innovation, the technology and the tools to achieve all of the other goals. Again, the funding has to enhance the healthcare systems, and it can't replace or supplant, that word should say supplant rather than supplement, existing Medicaid resources. So we're really being challenged to change the way we're providing care and paying for care in California, not just to backfill the significant cuts that we know are coming. Next slide, please. In terms of California and how rural we are, California is an incredibly rural state. So this is data, this is based on the federal definition of rural areas. So 57 of 58 counties in California have at least parts of them that are rural areas. 6 counties in California are entirely rural: Alpine, Mariposa, Modoc, Plumas, Sierra, and Trinity. And 2.7 million Californians, or 7%, reside in these communities. You can see that more than 82% of California is in a rural census tract. So this is all data that we will be presenting to the federal government as part of our application. We know there are significant numbers of hospitals, rural health clinics, tribal health clinic systems, FQHCs, in these rural areas, and have appreciated getting their feedback as we develop California's proposal. Next slide, please. In terms of permissible uses of funding, the NOFO, or the Notice of Federal Funding Opportunity, lays out 11 different permissible uses of funds that really overlap with the strategic goals of the initiative. So again, you can see there is a focus on improved health outcomes and chronic disease management. There is an ability to provide some provider payments, so there are some limitations there. You can see a number of permissible uses that focus on technology solutions, technical assistance to rural providers, again, a focus on workforce, behavioral health, innovative care, and collaboration. So I'm not going to go through all of those, but those are the 11 permissible uses of funds laid out in the NOFO. Next slide, please. We've had a very short time frame to do a lot of stakeholder engagement. The NOFO wasn't released until about 6 weeks or so ago. We did hold a webinar in September and released a survey, and are very appreciative to all of those who responded to the survey, who have sent us your ideas, who have come forward with offers of support. So we had 368 stakeholders who participated in our survey. You can see both significant participation from healthcare providers, non-providers, community-based organizations, tribal entities. So again, very much appreciate all of the concrete suggestions that came forward. So based on the combination of the federal outline and parameters and the stakeholder engagement that we got, HCI has developed an approach to California's application for the Rural Health Transformation Program. And our last slide, I'll spend some time going over those different elements that we have proposed. So we have three elements, three initiatives. The first is the transformative care model to, again, really try to change the way healthcare is provided in rural communities. We know that we need the workforce and the technology and tools to support that. So those are our three initiatives: the transformative care model, the technology and tools, and the workforce development. And all three support and supplement one another. So under the transformative care model, we are going to be focusing on maternity care, primary care, and chronic disease management, recognizing that rural clinics and hospitals are not going to have access to every specialist that's available. It's going to be really important to make sure that hospitals, clinics have access to e-consults and telehealth appointments. So we are looking to establish regional hub and spoke networks. So we'll have a larger hospital to be a hub, and then spokes will consist of rural, tribal, and FQHC clinics and some rural hospitals. So by aligning financing, governance, and clinical practice, we hope that the hub and spoke model strengthens rural communities to maintain those essential services and deliver modern patient-centered care to improve outcomes for chronic disease and maternal health. So again, we'll have hospital hubs that anchor the regional network with 24/7 specialty expertise available through e-consultation. And then the spokes will serve as the trusted local access points for rural and frontier communities. Also very important, we'll have outpatient nodes such as community health workers, promotores, and tribal representatives to expand the reach into the community. The networks will implement evidence-based levels of care to provide rural hub and spoke systems with a shared evidence-based framework for capabilities and transfers. So this is already happening to some extent. Some of it's informal. We're going to be accelerating the existing programs that are there, as well as developing new hub and spokes models. Each of those models will deploy evidence-based models in both maternity and chronic disease care to expand access, strengthen provider capacity, and deliver high-quality patient-centered care close to home. So that is the goal, for folks to be able to get care in their communities instead of having to travel long distances for the care that they need. So again, we'll be focusing on chronic disease management and primary specialty models. And then for maternity care, including prenatal innovations and perinatal mental health supports. We're looking to develop a rural payment model for rural hospitals, combining ongoing standby payments and service-based fee-for-service payments. We know it's very difficult. We know that many rural hospitals are struggling with financial stability, and so we're looking to have a new payment model where there is a stable base of funding in addition to fee-for-service payments that hospitals receive, and that'll take some time to develop. We also know it's important to expand and support rural workforce capacity, to develop the digital nervous system or telehealth components to support this. So again, the e-consult and telehealth will be critical to enable timely specialty access and patient monitoring. We'll also have some sustainability payments at the outset to try to stabilize our existing rural hospitals as they develop these hub and spokes models as part of our transformative care model. So our expected outcomes are really to improve access to evidence-based care, to increase the percentage of rural patients getting primary maternity and chronic disease services. So for each of these initiatives, we're developing outcome metrics and focusing here on folks getting primary care, getting maternity care, and getting chronic disease services in their communities. We're also looking at quality outcomes, reducing time to specialty referrals, time to treatment, and improved metrics for chronic disease and maternal care. Today, there is some rural bypass that happens, that people aren't getting care in their communities, and so we will also be monitoring that and working to stabilize rural hospitals and clinics, again, by reducing that rural hospital bypass, improving workforce retention, and stabilizing revenue streams. Moving on to our workforce development initiative, we heard universally from all stakeholders that workforce development is critical. So we'll be developing a number of initiatives to have locally grown, locally rooted, grow your own workforce initiatives, focusing on these target workforces on the slide. So in year one, we plan to do a statewide workforce mapping to really understand the workforce needs in rural communities. And HCI has been developing supply and demand models, and we'll continue to build on that, focusing it on, again, on primary care and maternity care. Based on that assessment, we will develop approaches to strengthen training pathways and clinical placement networks. We've got to get more folks in these communities into training programs so that they can serve their own communities. That's the evidence-based approach to developing workforce in rural communities. We know we need to have the clinical placements so that they can get their training locally. We plan on funding regional upskilling and cross-training programs. So to give an example, it's critical that primary care providers and maternity care providers receive training on behavioral health so that they can do diagnosis and early intervention for behavioral health needs and provide whole person care. We'll have a focus on expanding non-physician clinical roles, on strengthening graduate medical education and fellowships, and on recruitment and retention of workforces in rural communities. And then last, I'll talk about our technology and tools initiatives, which will be designed to equip rural health providers with the technical capacity necessary to strengthen clinical care and improve efficiency. So we've heard a lot from rural providers about the need to modernize their electronic health record systems, the need to make sure they have strong systems in place to prevent cyber attacks and the like. So we want to try to have some economies of scale and provide them with technical assistance. So we are proposing the development of a rural technical assistance center to provide coaching and hands-on support to improve connectivity and health information exchange, which will include electronic health record enhancements, data sharing, improvements, and cybersecurity fortification. We'll also be expanding regional collaboration with those hub and spokes models, making sure that they can communicate with each other. Also supporting opportunities like group purchasing and shared management of technological services. It is a huge strain on a small provider or a small clinic to do all of these technological pieces together. So we think it's important to try to leverage the state and this technical assistance center to try to do things like group purchasing and shared management of services. And then last but importantly, and the feds have focused on this, is the need for patient-centered digital tools to encourage these tools to empower individuals to collect some of their own information, share that. So there is a component around remote patient monitoring, information that a community health worker or a nurse can gather as they provide services to folks to manage their chronic disease or their pregnancy. That is a very high-level overview. Our application is due on November 5th, so we have just over a week to finalize our approach. States, again, as I mentioned, there's $50 billion available under this initiative. Half of those dollars will be funded to states equally for every state that has an approved application. So California could receive most likely up to $500 million over 5 years for that component. And then the other half of the funds, the other $25 billion, will be apportioned based on the scores that states receive. So we will be submitting our application in just over a week, and CMS has until December 31st to inform states of their outcomes. And with that, we have one last slide that gives some contact information. If you do want to really encourage folks to sign up to be on our mailing list, it's our State Office of Rural Health within HCI that's administering this program, but you can always reach out to our director's office for more information or input as we continue to develop California's application for the Rural Health Transformation Program. Thank you so much.
Thank you so much, Director. And the last slide is an appreciation again for all of you for joining us. That was a lot of information that we recognize was covered, but I want to again thank each department for leaning into opportunities to engage community along the way on these very significant changes across our programs. And we look forward again to hearing from you. So please do subscribe to receive updates, and we will continue to have these forums to have an opportunity to hear about the latest